Today we are the Chest AI panel being moderated by Dr. Saurabh Jha. We have Simon from Lunit, uh, Ryoungwoo from Coreline Soft, Naglis from Oxipit, and Faiza from DeepHealth. So over to you, Dr. Jha.
Thank you. So what I'm going to do is first introduce myself and allow panelists to also introduce themselves and give us a vision of where they see AI in chest going. So I am a cardiovascular and cardiovascular radiologist at UPenn, and I am very much interested in AI from both its efficacy and also the legal aspects. And I think that for chest, what we really need to see with AI is autonomous reporting with chest X-rays without radiologists in the lab for every single study.
Hello, my name is Naglis. I'm a radiologist from Vilnius, Lithuania. I'm also a co-founder, chief medical officer at Oxipit. And at Oxipit, what we are focusing on is primarily chest X-ray, and basically extracting and providing some very quantifiable added value, both in terms of diagnostics and efficiency on chest X-ray reporting. And as Saurabh already said, one of our main focuses is minimizing the time necessary to report the very routine and the most high volume studies, which are normal ones. And I'm very happy to be here to talk with my colleagues in the field.
Hello, my name is Ryoungwoo Jang from Coreline Soft. I'm a medical doctor as well as an AI engineer, developer, and researcher. So I'm in the clinical research lead in Coreline, and we do the chest imaging things. So we extract every information from chest CT and provide doctors what they can see from the what cannot be seen, and we want to provide them the imaging biomarker for their clinical practice and clinical patient management. Yeah, thank you. It's a great honor to be here. Thank you.
Good morning, everyone. My name is Faiza Admiraal-Behloul. I'm the chief product officer for Lung Just City DeepHealth. At DeepHealth, we are working on solutions or population screening for the major cancers, and lung cancer is one of the most important things. At lung pillars. So we're focusing actually on, of course, bringing AI for readers, leading the GIST AI, the just CT. So, but really focusing on the total workflow, bringing AI not only at the pixel level, but helping also reporting, auto impression. Our focus is really to empower the radiologists to do this work better, faster, so that we can treat more patients with me. So very happy to be here as well, and very looking forward to hear from my colleagues from the field also on our
Hello, everyone. This is Simon from Lunit, and I'm the head of the medical affairs department and cancer screening group. Lunit is focusing on primarily on the chest X-ray AI product and the breast imaging area also. So speaking more focused on the chest area, we are looking for some ways to increase the level of autonomy of AI in this chest X-ray workflow. So that does not mean necessarily that we want to just replace the radiologist, but by increasing the level of autonomy in the workflow, it can directly benefit the non-radiology physicians and the patient care also. So that includes, of course, the normal filtering and some kind of free population reports, even for the abnormals. And we are seeking for the clinical value and the impact for the healthcare society. Nice to meet you, everyone.
So there's a rule. You won't use the phrase replace the radiologist until 6 p.m. months. So we have a fairly diverse in terms of geography and also in terms of location or use of AI in the chest X-ray. So the commonalities here are going to be the challenges which everybody faces. And so the first challenge really is the chest X-ray is a two-dimensional representation of pathology, and there's a lot of, with the radiologist, intra-observer variability. One radiologist calls pneumonia, the other radiologist calls atelectasis. So the fundamental question which bothers everybody is it pneumonia or is it atelectasis? So I want you to give me an idea on what you have done in order to make this distinction. What gold standards you use, what labels you use, uh, and how you've gone about.
Infectious etiology, pneumonia, or an actual cancer, or was it mainly just like a superposition with radiologist deems suspicious to be followed up? So if you have that sort of data, and and I believe most of our colleagues have, it's way harder to collect large data such data, but you can certainly try that. But so what I would mention in that same topic, that at least from our perspective, our main focus is, I would say, not, let's say, differentiating findings from, atelectasis or consolidation. Because I would say, as a radiologist as well, at the point when you open a chest X-ray study, when the radiologist needs to open the ceiling of the AI added value is already very greatly diminished. Because even without the AI, reporting of chest X-ray in many cases will take 20, 30 seconds. So AI can maybe bite off like 5 seconds out of that, but it's certainly not primarily aimed to perform a differential between complex abnormalities that's still in the workflow of the radiologist. What can AI do quite well, and what we believe the most value can come from, is take that spectrum of the studies where it can say there's no suspicions about regarding anything like atelectasis, consolidation, no need for further investigation, and that's where most quantifiable value can come.
Yeah, so I totally agree with the point of Naglis, and I want to express it a different way. So for the medical doctors to manage the patient, if the patient comes to the hospital and take a chest X-ray, it acts like a surrogate. So it's just a shadow as the 3D structure is projected into 2D image. So it's just a projection. However, it can act like a gatekeeper, whether to do some kind of other procedures or medications to do the patient. So yeah, that is the first point. And the second point is then many companies do the triage system or abnormal versus abnormal triaging. So that is some kind of act as a surrogate, as well as you can it is not the interpretation of the chest X-ray that AI will do the best. It is a kind of whether what to do to the patient. So you don't have to diagnose a patient with a chest X-ray. This is a pneumonia. This is atelectasis. But you have to do the patient for what we can do for the patient using this chest X-ray and AI imaging. So yeah, that's my point.
Best one pick solar theaters.
Let's use the page for.
Yeah, so I'll just add a few words on so generating the labels for the training. Yes, our moderator has mentioned. So, in the clinical perspective and everything, I 100% agree with it's two people already have mentioned. And so because of that, those kind of factors, we do not really care that much about the exact differentiations between the complex ecologies. And just in terms of generating the labels, we do, of course, we independent labels from the different radiologists to make the training data and the validation data to be more hybrid. But actually, we pay more attention and put more resources on generating the correct labels or an indeterminate lesion that is confused between whether this is a true lesion or just a normal structure. So basically, we do many CT paired comparison data for our training and validation. So we more focus on trying to make a solid ground truth or the negative cases, basically. So we really wish to avoid the situation that's, just a osteochondral junction shadow can be just it falsely noted as node. So we primarily focus on seeing those kind of false positives rather than trying to clear differentiate between those complex abnormalities.
we will get the chest CT. So we'll stick with the chest X-ray for now. So I think all three of you basically said that primary purpose of high chest X-ray is in triaging to normal and abnormal. You don't get into the weeds of classification between broad-based pathology like pneumonia and apoptosis, which needs to be manically triaged. And though there is some reliance on the radiology label, we're all aware that you not apply it too much because the radiologists themselves see very frequently interrupts over very better. Sticking up a theme or a chest itch. Second question I will ask, and I will go in reverse order, which is one of the major uses of the chest X-ray is in finding out the position of support lines, central lines, endotracheal tube, and chest tubes. Can you give me where you are with that and what you would do to get busy? Starting off with the dunes.
Yeah. First of all, it is quite difficult to really define the actual correct position of the tubes usually because sometimes the position of the tubes may look a little bit suboptimal, but if it's clinically just working well, and if we do not want to take the risk of trying to adjust the position or on the patient who is at risk in all the vital signs, then they would just use as is. And but I mean, that's kind of like innate difficulty that because, we have to always compare with the previous ones and then decide on the optimal position, whether the current position of tubes are optimal with that. But anyway, seeing aside from that topic, just our current situation of the tubes, we have recently internally developed some tube detecting algorithms by utilizing some foundation models. So not only just detecting the tubes, it can just basically detect all potential findings existing CSRs. And we are primarily focusing on the endotracheal tubes, NG tubes, and the central venous catheters, and including the positions that we can generate the presence of the tubes and whether the position is optimal or suboptimal. But of course, lab can really vary a lot according to the predisposing factors. And it's and in order to predict the positions, that is impossible with just teaching the models in the classical CNN ways. Telling all the models with all the training data saying that this is suboptimal and this is optimal. It's just training in those kind of beta binary labels that not necessarily lead to a correct prediction because measuring the distance between the endotracheal tube and the carina, that's very, very pixel specific, and that's not something that CNN can learn from the total image. So we basically teach the model to specifically find for the tube tip and the carinal structure and just measure the actual pixel distance between those two. So basically, we have all those kind of multiple detection modules in time, but in parallel, we have a separate tube-oriented module that can be also integrated into the final product.
Okay, so for the that kind of topic, I'd rather say, but I'll depict this situation in a different circumstance. So let's say that you have an algorithm that classifies a lung cancer screening subject from the normal subject. So most of the patients will have a normal chest X-ray or chest CT. However, just few of them will have a abnormality and lung nodules and lung masses. So what I want to say is that if you measure that as an accuracy, you don't get anything because AI algorithm just learns that, oh, if I say just normal, I get 99% accuracy. That is the pitfall. So what I want to say is that if we accurately, just like 1 or 2 pixels of error margin to train the model that the carina is located just exactly to the at the bronchial tube, that is not the
important point. What is important is that you have to see the patient. You have to get some clinical relevance. So as Simon mentioned, you have to see whether this is clinically meaningful and clinically acceptable. Yeah, so I don't want to focus on the technological point, but rather in the clinical aspect. Okay.
Yeah, so I think many important and good points have already been said. I generally very much agree. What I would mention, let's see, from our company side, so we also have modules and findings, including the identification and evaluation of central venous lines and the tracheal tubes and nasogastric tubes as well. And that is quite a good use case, especially for the types of institutions that have many inpatients and so forth. In regards to what's the best application and use of the AI, so maybe I would argue that it's probably not possible and not sure if that important for AI be able to do it instead of a radiologist, because again, it comes down to for a radiologist, it will take a couple of seconds, and is it really worth trying to get there, especially because what Simon also said, that evaluation of these factors very often does not lie on a single image. It requires clinical context, it requires priors, and before, let's say, AI algorithms do get access to that information, it will probably never be a replacement for the radiologist. But again, the question is what you are trying to get from the AI, and it's certainly not replacing the radiologist in most cases. So generally what works right now is, first of all, trying to, alert institutions. It is quite often the case that after hours, radiologists are not always present. So for example, our doctors want to know ASAP that tube has been malpositioned or it is likely to be malpositioned. And for that, AI works really quite well. And, the accuracy and prediction, value is really quite high to identify, for example, those cases and prioritize them, that someone who will take a look at our status and take action. And on the other side of the spectrum, what we also do is sort of reverse this use case, use the AI as a quality assurance tool, which we call our product called Just That Quality, which basically looks among other findings for malposition of the devices, which are actually reported as proper position, and call out for a quick second look. So there are specific type of application where AI can bring value, and I would argue there's no need to get an algorithm which would be a replacement for radiologist for this particular use case, but they actually have its own place in the diagnostic portfolios.
So thank you for your insightful talk. That is the exact point that I mentioned. X-ray is a gatekeeper. I want to add that on. Thank you.
Okay, so this is the last question of the chest X-ray. And here's a scenario, a hypothetical. Trump is president, and Elon Musk is quasi-president. And Elon Musk wants AI to read chest X-rays autonomously. So the question for you is, are you willing to work with him? And how far are you from autonomous AI, and how will you get?
Yeah, so let's say the hypothesis is valid, and I want to work with them, not just like a yes or no question, but I want to work with 70% believer doctor.
Elon Musk. Yeah, he's gonna get all the money.
Yeah, that's hard question. So it becomes much more harder. Okay, then I'd rather work with him because, yeah. I was thinking about another thing, but I have to take just 5 seconds. So please. So I work with him because the it's a hard question.
So how will you make AI autonomous really prestigious? So there would be 2 years.
Okay, then for the autonomous chest X-ray reading, there can be some kind of many technologies that from the generation of chest X-ray report or just triaging or CADX, whether this is just a perfect tool. So I rather say based on the chest X-rays like functionality, whether it can generate report or it can detect nodules, I can just like reduce my workload or I can make assurance of my diagnosis. So it will be a much more better way to work with the chest X-ray AI rather than let Elon Musk report all the chest X-rays. Yeah. Okay.
Yeah. I would work with Elon Musk if he would allow us to use some of the H100 GPUs. No, trip joking. So, for the autonomous AI, we are definitely heading toward that. As I mentioned in my introduction, it's all about the level of autonomy that we have to define. So, although we are keep pushing towards fully autonomous in many areas if in the field, not only in the industry, in the medical industry, but for example, like looking at the Tesla. I mean, you it mentioned about Elon Musk, so they're you're really pushing for the fully autonomous driving, but there are many kind of limitations and constraints on that. So when we think about the fully autonomous X-ray, I mean, even if we generate a really fully acceptable 100% accurate recording out of a single image, that is still not clinically, that cannot still work as an autonomously working AI in the actual clinical field, because they have to compare with the priors, and also it is very, very influenced by the actual indication and the reason of the exam. So in order to achieve that really clinically fully autonomous working AI, that is, we have to go on the multimodal causation models that includes direct input of the patient history and indication and the previous images, and even laboratory findings, and even, I don't know, maybe EKG findings or some other tests. So that might be possible. I mean, theoretically, nothing's impossible for that. But we also have to think about the ROIs in terms of the overall health economy. So how much resource are we going to really put for this chest X-ray, which usually work as a gatekeeper, and it is already being reimbursed in a very cheap price. So yeah, that's the balance that we have to. And I mean, but in our company, just generating the most acceptable or full reports out from single image, that is being actively developed within Lunit. And actually, we can see the demo in our booth about that. So if you have time, please join booth. But still, there is still a long way to go for the actual fully autonomous AI in the clinical field.
Yes, very wide question. Probably not going much into politics, but in terms of Elon Musk providing infinite power to do autonomous, or I say third of autonomous. Well, in terms of Elon Musk, I think recently I saw in tweet a statement that Grok is already quite good. Please go ahead and upload your chest X-ray studies, which I very highly disagree with. So I will be very hesitant to work right now with him. But in terms of autonomous AI, so generally, first you have to define what do you mean by autonomous AI. Is it automating normals, or is it automating chest X-ray in general? So in terms, right. Well, regarding automating normals, just on our standpoint as Oxipit, we have been quite prominent in the field. We have the first European certificate for this intended use case. But again, you need to highlight that generally it's not binary that you just click and it's autonomous. It's still a road to get there, whatever. You need a lot of safeguards, a lot of validation, and it's not like you are non-autonomous and then suddenly autonomous. And then in regards to the question about automating all chest X-rays, so I'm really hesitant about that, to be honest, because I see that it is certainly feasible to automate certain fraction, maybe a quite large fraction of normals. But in terms of abnormals, there's no clear current road for that because of a wide variety of factors, but one being not intrinsically limited by the AI itself, but by the information which AI receives. And I would argue that it is not impossible to imagine a scenario where AI is able to do, like with foundation models and all that sort of stuff. But I would argue that probably before we get there to a point where AI says it's normal, AI says it's not normal for whatever reason, and then it goes to, let's say, some extremely low dose like CT automatically, where another AI can do a way more better differential diagnosis not trying to reverse engineer radiologist reporting on a limited resolution study.
Great. So, 2 out of 3 of you got Musk's $100 billion. So, we'll play the money. So, now we'll move to ChatGPT. And I'm going to start with DeepHealth. So, the question for you is quite simple. In the US environment, with chest radiologists reading lung cancer screening CT, not all the time, some of the time, and it's not the most difficult exam in the world to read. It's boring, but it's not difficult. What is your value and what's the business model you have?
Yeah, I think you said it's boring. And I think a radiologist is a highly skilled professional. Brings value when it is looking at different cases, and really that's the value. Not that looking at, as you said, maybe 98% of easy that one, but still just CT low dose or not the same. Few messages you have to go through also all the other incidentals, right? So they probably will find boulder finding. So and you have to report on that. You have to do it quickly because you have so many of these when you are disputing. The volume is just way more than what you could tell. Although only in the US, the adoption rate is still relatively low. So the value is exactly that. I think the AI for just CT and screening is really to make sure that the radiologist get, to look at the images where his expertise is most needed. Most of the time, it's going to be normal, and the AI can help either triage it or at least quickly go through it and say, well, nothing to look, and help also give a recommendation. You can go all the way to saying, well, maybe you want to see it. And maybe also we are working into also, pre-filling the reporting for them so that they don't have to waste time on something that is not worth you right now.
So if I understand correctly, you're a nodule detector, flex the nodules, pre-fills the record. What about the rest of the chest CT, like the coronary calcium, heart size, and other things, lungs?
So technically, we have all the solutions. The biggest problem is that the radiologists don't want to pay for that. So pretty difficult to make a business. Honestly, it is very difficult to have a sustainable solutions when most of the radiologists don't see the value of that. So if we just think about it just technically, and it makes sense, right? But very often, radiologists don't see the value of having all this extra. So they want to have all of the knowledge because it's a chest screening program, or else it's the lung cancer screening program, so they need healthcare. And we're seeing now programs coming in Europe, mainly where they say, well, maybe you should also, to get cost effective, they would like to find also with AI the other indicators so that they can, go with the volumes mainly. But the value of detecting it, the radiologist can do it very quickly as well. And reporting on, for example, classification is very big. So they don't see the value of having AI there. So we can break it. They did it notify.
So the value that they ask for is purely on the nodule side of things. So when your solution looks at the nodules, do you give us chance of malignancy as well? If they're not, you put it in the records, the science, image number. What would you do? Just give us an idea.
So what is viewed today in the voter is based on the size. Depends just on the location. We can also do some sporing, and then we can give some even order. But we are also working on the malignancy sporing, or also the malignancy prediction. So these are still in development, in research, and here as well, the radiologist doesn't know what to do with the score. So technically, we have it. It's currently research as well. And it's mainly the pulmonologist was interested in it. If a radiologist says, well, at the spinning, I don't know how to fill in a cancer spore, I hate to just go breads. Do you want to help me? Help me do what I'm supposed to do quickly. So again, the technology is there, but the adoption is not ready for it yet. So it's more of a problem giving them something and they are wondering what to do. And so we need pilots. And I don't think the radiologists are today ready for a cancer spore added on information because they have to deal with it, that they have no standard for that. However, the pulmonologists are very, very heavy somewhere, so we're exploring it as well.
Right. So the theme there is that when you give added information, it's not always welcome because people don't know what to do about it. So I think somebody mentioned earlier on that these solutions look at things that the eye can't see. So can you give me an example of that? If the eye can't see it, how do you know that it's real, insignificant?
So if I understand the question correctly, there are you say that there are some cases where AI can perform a certain task better than the radiologist because I would thought it is
See things that the radiologist can see. So
well, I would say there's a limited things that AI can see with a radiologist can in chest X-ray. But let's see, in using the same example, like I have reported my those of chest CTs as well. For example, I certainly believe in the use case like that AI can perform classification to predict the malignancy score on any particular nodule, possibly even better than the radiologist can. Because, what radiologists use are, quite well-established guidelines like Fleischner and a couple of others, which essentially try to do the same thing. But they're all based on, somewhat relatively straightforward features, which can be manually extracted by the radiologist. So in some cases, in particular, chest CT and maybe other use cases, like, for example, predicting malignancy spore on a liver lesion in CP and so forth, there certainly are indications, and I think exists in literature that it can do that same task. But it all comes down to, what do you train on? If you actually train on the radiologist data and radiologist annotation, you will never exceed the radiologist because that was your ceiling. You might get very close, but not much on top of that. But if you're actually training on something that is arguably better than radiologist, like all of current CT, biopsy result, and so forth, then you can actually probably make AI see something what's like radiologist I cannot see.
my God, I have a lot to talk about this topic. So first of all, our value and our business model is that we do the chest CT imaging, but we extract every information from the chest CT image. For example, we do the BMD from chest CT and abdominal CT, and we do the pattern analysis for the lung texture and ILD, and we do the low cancer screening. We can extract coronary artery calcium score from the low dose CT itself, and we can even extract functional vital capacity from the chest CT image itself. So I implemented and developed that algorithm. But so you ask about what is the value and what is the belief level of the AI algorithm that radiologists cannot see, right? So I want to say radiologists cannot accurately measure coronary artery calcium score from the chest LDCT, but we can. We have validated that in a very large cohort, and we have adopted an algorithm in a regulated setting. And you can, even radiologists cannot assess the PFT from the chest CT image itself, right? Who can do that? Who can this patient has FVC of 2.7 liters. Nobody can say that. But with the AI algorithm, we can do that. So we have developed the PFT prediction algorithm from the chest CT, and it can be utilized in the ILD, pneumonia, or other various clinical chest CT imaging settings. So I want to say, not just predicting just one score, like malignancy score from the chest CT and lung nodule image, but we have to make a imaging parameters based on the chest CT imaging, like PFT or other some kind of other things that can be logically extracted from the chest CT image.
So I think that discussion goes back to what Naglis mentioned. So it's all about how you train the data and how you make the ground truth for that, actually. So if the AI is trained and intended to detect something that can be perceived by the in the image, then even if the AI proves to perform a little bit better in terms of the AUC or something, the radiologist would not easily accept that. But if these informations and outputs and training data are coming from some other sources that can work as a real true ground truth, that can be more easily accepted by the radiologist. And actually, I'm seeing that a lot of times in discussing with the breast radiologist, but using our breast product, because that is basically built on the training data ground truth by the pathology biopsy. So, and oftentimes when there are discrepancies between the AI results and the radiologists, it turns out that the AI results shows that the radiologists could not identify in the image itself, and that is possible because that was trained on the biopsy ground truth. So, and actually the radiologists reading the memos, they tend to accept better on this perspective because, oh, okay, this result might be a false positive, but this AI has been trained on the pathology ground truth. This might be seeing something that I cannot see. So it's really based on the training data's ground truth and how it is intended to be used and what would be the actual output for them. So that's all.
So I think the example of where the AI can see something that the radiologist cannot see is indeed what you mentioned. So example is the cancer prediction or the malignancy prediction. The radiologist, we have to ask patient to convert weight EMAs for a year. Maybe he needs that follow-up today to make that decision. So there are many, the literature you can see, and also it published that there is their true value that the AI has been validated against pathology. So that's a true value. But again, the information is because of the regulation and the standards, they cannot rely today on this data because it's not 100% in any space as well. Yeah. And just to answer on the question of the accuracy, I think the radiologists today, they have standards and the way they report. Usually for calcium scoring, they just want to say it's low, medium, high, and it's enough. If it's 99.2 or it's 100.1, it doesn't change the way they're going to validate. So this is why they don't see always the validate. It's very easy for them to jump, especially when they speak it, and say, well, I can give a 3 level estimate of how severe the disease is. So that's where the value is not. Technology is perfect and do it, but they don't see the value, and then it does power. So we obsess over really trying to find where can we help them do their job better. AI is not here to replace, it's really to make sure that where can we help them, and really we listen to the radiologist. Where can we help you? That's why we have. And I think malignancy score as a way to maybe something to the patient instead of just waiting for a few manuals.
So last question. What are you going to say to the American radiologists to encourage them to adopt your product? Hi, the American radio.
Well, I would say it all comes down to data. So when you are talking to radiologists, and again, when you're trying to sell a commercial AI products, another copy, you would talk about very different things when you're talking either to the radiologist or to the radiology AI manager or like some financial department as there's or for example, you like talk to a patient representative because generally they have very different primary interests. But generally what we are trying to achieve with AI, you could say ultimately, better patient outcomes, but then it should be facilitated by better availability of radiologists, better mental state of the radiologist, and also, better accuracy in general. So generally what we are trying to achieve with, as well as our colleagues, are, very broadly two things: efficiency as well as accuracy, optional both. So in terms of the autonomous automation of normals. What problem we are trying to solve is that worldwide we're still performing a very large volumes of radiologists. And then some markets in particular, patients do suffer because of delayed diagnosis and the lack of radiologists to report this very, very much routine study, and the situation is unlikely to be improved. And there are measures to address that. It takes a while. It's, as mentioned, autonomous AI should not be plug and play, and you should do it responsibly. Should have data available that you can do it responsibly and safely, and that's what AI can provide.
Hence, convince me to use the products.
Well, I'll quote a sentence and a little modify it to convince you and appreciate you. So, Curtis Langlot, the head of the North American Society of Radiology, last year he talked like, AI will not replace radiologists, but radiologists who use AI will replace who don't. But I will change a little bit. Radiologists who use smartly and clinically use the AI will replace the radiologists who don't, because just the technology itself cannot change the medicine. It's a system. So radiologists who use AI systematically will change the radiologists who don't. So you have to use the radiology. You have to use the AI. Okay, that's my bad.
I think what the first question to convince a radiologist to use something is not to tell me, this is my technology, this is what is good for you. How can I help? Honestly, all radiologists have the same problem, but depending on where they are in their level, in their career, and also, first, how can I help? And then based on that, you can show. But if there is one commonality, and I think you said it, is the boring job can be, that's where we can. And the boring is defined by the radiologist, and that boring is not about one like. And that's where AI can help. And I think you'll have to listen, and then, you decide if you need it or not. And if you don't need it, it's okay. Because when you need it, it should be there for you.
I know that you don't want to read the chest X-rays. I know that the radiology departments in the U.S. is heavily understaffed, and we would like to take that works that you don't want to do, and we'll be there for you.
Great. I wish dating was as convincing as this. Well, thank you very much, and appreciate your thoughts. Thank you to CARPL.ai.